Welcome, everyone, to our webinar series, Facial Fat Grafting. We're delighted to have Dr. Jason Bloom and Dr. Samuel Lamb join us for this series and this session. Quick housekeeping notes. Webinar is view only. You won't be able to turn your camera on or unmute. However, there's a Q&A button at the bottom of your screen, and you can ask questions to the presenters. Chat won't be available, but all the questions will be addressed, during the presentation, or most of them at the end of the presentation. And as you can see, this event is being recorded for note-taking purposes. And you might want to just shut down any unneeded applications to boost your bandwidth. And also, if you have any questions, please contact Bimini Health Tech. We'll have this email address at the end of the session as well. So now I'd like to just introduce Dr. Jason Bloom. He is from Bloom Facial Plastic Surgery in Villanova, Pennsylvania, and also Mainline Center for Laser Surgery in Ardmore, Pennsylvania. A little bit about Dr. Bloom. He received his medical degree from the University of Michigan Medical School, graduating with distinction. He also completed his training at the University of Pennsylvania Department of Otorhinolaryngology, head and neck. He then went on to do a fellowship at New York University, the Department of Otorhinolaryngology, facial plastic and reconstructive surgery in 2011. Currently, he is the Facial Plastic Surgery Fellowship co-director with the American Academy of Facial Plastic and Reconstructive Surgery, as well as the American Institute of Aesthetic Medicine as medical director. He was co-director with the ASDS, the American Society of Dermatological Surgery, and the American Society of Laser Medicine and Surgery for fellowships and preceptor programs. Welcome, Dr. Bloom.
Hi, guys.
And Dr. Sam Lamb, he is from the Lamb Facial Plastic Surgery Center in Plano, Texas. He earned his medical degree from Baylor College of Medicine in Houston, Texas. He then completed a general surgery internship at Columbia University College of Physicians and Surgeons, which after he completed a residency in otolaryngology, head and neck, also at Columbia University. Dr. Lamb completed a facial plastic and reconstructive surgery fellowship at Williams Center for Facial Plastic Surgery, Albany Medical College in Albany, New York, followed by preceptorship for Asian facial cosmetic surgery. He is currently the president of the American Board of Hair Restoration and on the board of directors for the American Board of Facial Plastic and Reconstructive Surgery. Welcome, Dr. Lamb.
Thank you.
Just a quick overview of our agenda. Dr. Bloom will present on obtaining optimized fat grafting results with specialized fat purification and sizing techniques, followed by Dr. Sam Lamb. He will present his philosophy and strategy with fat grafting. And then we'll have a Q&A, and we promise to answer all your questions. So with that, I'd like to welcome Dr. Bloom.
Well, thank you so much, Diane. Appreciate that. And thank you to Bimini for having us talk. And my talk is really about how I have gone through the trials and tribulations with things that have worked and things that haven't with fat grafting techniques, and how I've kind of come to find a few different ways and really have honed in on these specialized ways to purify my fat as well as size it for facial fat grafting. And we're facial plastic surgeons, so for us, this makes the most sense. So fat transfer and fat grafting is really a multi-step process, and each of those steps has different challenges in order to receive really predictable results. Well, there's different kind of variability in the patients. You have to choose the right patients, and are they good candidates for it? They have different skin thicknesses. Then when you're harvesting or lipoaspirating the fat, there is different variability in the sites. Are you going to take from the lower abdomen or the inner thigh area or the outer thigh, or what's your favorite different area, and how does that affect the fat? And then how do you clean or process or purify this fat? There are so many different ways out there, whether you're centrifuging it, whether you're using a gravity method, whether you're using a closed system like Pure Graft. And we're going to talk about all of these different steps. And then finally, the different areas, the various areas to deliver it in the face and how you deliver it with different size cannulas and things like that all affect the ultimate viability and the results of your fat grafting. So I've had many previous issues with fat grafting, and that has kind of led me to my current state. But I've had cases where the patients just have had prolonged downtime with increased swelling or inflammation or bruising, lumpiness, inconsistency of the fat. And then if you process the fat too much and break it down, you're really, you can get none of the structural components. You may want like the nano fat, which is, really just the, you're not getting any of the volumetric components, but you're getting the SVF or the stem cell components of it. And just the opposite, if you can kind of like, we'll talk about emulsification and things like that, where you're actually breaking down the regenerative components of those fat cells. Sometimes if you don't get a size that you want to re-inject the fat, it can be difficult to inject. And then obviously there's a lot of variability with the longevity based on how you process it. So the first thing is, does purity matter? Is having a pure fat product important to what we do? And I would say yes. And this has really come from a couple really interesting studies. And this first one was from the ASJ, and it was surgical decision-making in autologous fat grafting. And it showed that, there were a bunch of different factors that led to increased inflammation, decreased graft retention, meaning having free lipids in the fat. If you had more red blood cells, more white blood cells, or more fluid like the tumescence. So those four things, having broken fat cells and free lipids, caused more inflammation. Having red blood cells caused more bruising. Having white blood cells, you had increased inflammation, and having more tumescent fluid that you could, there was a lot of variability in your grafts. So that led me to thinking, and we now have a bunch of different options for fat grafting, whether you're using a gravity method, whether you're using straining, whether you're using centrifuge, or something like Pure Graft. And the graft preparation is not equal. These were 3 different specimens that were processed with gravity, just letting it separate out, centrifuging it, and then looking at the fat. And then finally, Pure Graft, you can see the consistency throughout the entire graft specimen. And the nice thing about Pure Graft, and if you haven't used it, it is not only is it nice to use, but your OR staff will love you as well, because from the moment that you harvest the fat to the moment that you re-inject it, it's really in a closed membrane system. It's not touching the air at all. So it's not mechanical, doesn't need batteries. It's just facilitated by gravity, basically the passive flow of fluid through this thing that looks like essentially like an IV bag. And there's 3 different sizes. There's the 50 cc, which is really the only one I use. If you need to process more than 50 cc's of fat, you can actually run the fat through it again. There's a 250 cc bag that a lot of surgeons who do breast surgery use, and then a bigger bag, 850 cc's for the body. And this is just, I'm not going to go through this whole thing, but this is just like a comparative matrix of all the possible things that are on the market today. And you want to remove contaminants, not traumatize the tissue. Is it closed membrane? Meaning, is it open to the air? How quick is it to perform? Is it easy to do? And what kind of capabilities for tissue volumes can you do? And you can look at this, but I'm going to show you why I've chosen Pure Graft. So the second thing that kind of led me to this was this article, and this was in PRS, and it was by Zoo. Here's the reference at the bottom here. But what they showed is they looked at the Pure Graft after fat. They looked at the different fat grafts, and they looked at lipid content, white blood cells, and red blood cells versus centrifuging, as well as the gravity method with straining. And it wasn't even close, significantly less lipids, that's the broken traumatized fat cells, significantly less white blood cells that lead to more inflammation, and significantly less red blood cells with the Pure Graft, as you can see here. And so as you could see from the last study, those three things were really important to graft retention. And so if you have something that delivers truly a 97% pure fat product, that got me thinking, why am I not using that? But if I was using it, and this is from that same study, I wanted to make sure that not only was my fat pure, but I was also getting the stromovascular fraction, the angiogenic growth factors that we love about fat so much, that give us this like amazing kind of regenerative aspect of the fat. I wanted to make sure that we weren't losing any of that. We weren't over processing the fat. And what they saw in this study was that all of the growth factors were essentially the same or better than centrifuge. And you can see this is what the Pure Graft looks like. It's just basically, it's a 74 micron filter as well as an 800 micron mesh. And what you do is you put the lipoaspirate in the right port, you wash it with lactated ringers. I wash it twice, and then you get the tissue out of the tissue port after you drain out the contaminants. Now, it's nice to see how it worked, but does it really work? Does it work clinically? And there's two studies that I kind of have seen. The first study was actually a breast study, and this was done in ASJ. And what they did is they looked at 1 year follow-up on 26 patients or 50 breasts, where they used Vectra 3D imaging. And when they were fat grafting the breasts, they overcorrected it visually by about 30%. And what they showed, based on their Vectra imaging, after a year, that about 25 to 28% of the injected fat was resorbed. And so it was like a net, like, if they over grafted it by about 30%, they lost 25 to 28%, and they got the results they wanted at a year. And both the patients and the surgeons were very happy with it. And then from the AAFPRS, the facial plastics literature, the Glasgolds kind of wrote about this for fat grafting. And what they showed is this was, again, a 16 or 17-month study. They looked at 26 patients or 52 hemifaces. And what they showed was that using the closed membrane system produced about a 10% better uptake, 41% versus 31% at 17 months versus the centrifuged fat. So those two studies kind of showed me, like, why am I not using this to graft my fat? And now those were some of the things that led me to start using really the Pure Graft to purify my fat. So that's the first step. When you're done with the Pure Graft, you're getting purified fat. But the age-old question, does size matter? Is having microfat important to what we do? And I would argue yes. So why is microfat really important for regenerative facial rejuvenation? So microfat, for me, represents the ideal size that provides both the structural volume that we want with fat grafting, as well as the SVF regenerative processes. And basically, you can inject it through a 21 gauge needle or cannula if you want. And the fat is processed I would say it's like Goldilocks and the Three Bears. It's like it's processed just enough to remove the contaminants. You get the size you want, whereas all the other stuff is removed. So you have a high viability of fat with, again, if you use something like Pure Graft 2, you're getting purified fat, and then the size is important here. So when you harvest fat and don't do anything with it, you're getting the parcels of fat can be greater than 2 millimeters based on the harvesting cannula that you're using. And that's anything greater than basically 2,000 microns or 2 millimeters is macro fat. That's good for breast, body, large scale volumizing, for reconstructive purposes. And it really, it doesn't matter if you're using these large volume areas. But when we're injecting the face, specifically areas where the skin is thin, the tissue is really delicate, like around the eyes and in the face, microfat is really where it's at and perfect for the facial rejuvenation purposes. So microfat is really anything from 700 microns to 1,200 microns. It's easily aspirated, and it's perfect that it allows that structural component and still has the SVF. Then nanofat, which I don't even like the word because it's not fat. Nanofat has it's just liquefied matrix, the stromovascular cells, the endothelial cells, and there's actually no adipocytes in nanofat. That's because you're rupturing the fat cells, and you do it more for the kind of regenerative properties to get the growth factors out of the fat cells. But anything less than 700 microns is considered nanofat.
Hey, Jason.
Yes.
Good question. Are you when it's passed through the Pure Graft system, are you counting that as macro or micro? Does it need another level of processing to get to micro?
Yes. So that's still macro. And when you take it out of the Pure Graft, you'll see, because the Pure Graft, when you wash the fat with lactated ringers, and I'll show a video of it. It's very kind of clumpy. It's almost like it dehydrates the fat as well, because you're taking all the water and draining it out, and it's very clumpy. It injects almost more like a thicker filler. So that's why kind of breaking it down, this micro fragmentation of fat, which I'll show you right here, chopping it down into smaller sizes will allow for easier grafting. It's easier to go through a smaller cannula and still gives you the fat sizes we need.
And what size cannula are you injecting with?
I typically use like a Tulip SL 19, 20, and 18.
Okay.
Yeah. Okay, so once you harvest the fat, I process it through the Pure Graft, and then comes the sizing step. So now I've got my purified fat, and then I size it based on these things that are called Pure Graft Boost. There's a 1,500 micron sizer. It's basically a screen with cutting blades that chop up the fat and microsize it. There is the 1,000 micron, which for me is like, that's the perfect size. So you can inject it through as small as like a 21 gauge needle or cannula. But I tend to use the Pure Graft Boost 1,000 for all of my fat grafting cases. And sometimes I do want to add nano fat or some of the rejuvenations where I'm injecting it into the skin for kind of rejuvenation qualities. And then I'll go ahead and process it after the 1,000. I'll take it down one step further to make nano fat, and so that I can inject this kind of like into the skin more at the 500 micron level. So one of the things that I was using before they created the Pure Graft Boost was this option, which is the Dermapose Refresh. And for someone who's just getting into fat grafting, you don't have all of the tools to buy. This is really neat. It comes as a single kind of kit with this 14 gauge harvesting cannula. It's kind of like a Miller harvesting cannula. It's very atraumatic. It has this inner syringe and has two sizing filters in it, an 800 micron and a 1000 micron. So when you're done with this, you're getting 800 micron micro fat for injection. So that's why you're getting both of these screens to size it appropriately. And I'll show you, this is, so I just harvest the fat, and then what you do is you kind of push it through, and I'll show you what that looks like. You end up losing about 5 cc's of the fat here, but you pull out, I mean, if you look at this fat now, it is nicely purified, and now I have this fat, it pulls out the inner 30 cc syringe that you can transfer it. So here, if I can click on this, let's see if this plays. Oh, maybe not. Oh, wait, hold on. Okay, that one, great. So you see me transfer it into the syringe. And now if you play the one on the right, or here, oh, let's see that. Okay, so you can see this fat. Now I'm injecting it. This is like a 19 gauge cannula. It's very consistent. So this is what I've been using recently, which is the PureGraph Boost. These are the adipose micronizers. They're basically size screens that have dual blades that cut, they cut the fat up into precise sizes. And this is what it looks like. This is the PureGraph Boost 1000. It's what I use for all of my cases. Now, let's see, can you play that? So they're sold separately. Let's see if I can get that. There you go. So what you do is you just pass it back and forth through this screen wheel. I use 220 cc syringes, and it cuts it up. They're sold separately. Basically, a box of 10 is $1,000. So they're $100 a screen. I just added onto the cases, and different sizes. Okay, the one thing that I will say, there was this study that came out that was pretty shocking to me. Some of these things, which are really small emulsifiers, right? So that you can take it down from a bigger size to a smaller size, but this is not a screen. This is putting it through this tube, and you're putting it through so much pressure. The screens that I just showed you with the Dermapose Refresh and the PureGraph Boost have a bigger surface area. When you're using these emulsifiers, and some of them break them down into nanofat and some of them into microfat and some into nanofat, but this study showed that emulsification actually changed the viability of the SVF, so that the adipose-derived stem cells were not as viable when you really emulsify it versus micronizing the fat. And I was shocked by that. So this is quick. This is like an 8 times video. So here I'm taking the fat that I just harvested, and I'm putting it into the PureGraph. And you can see it's orange. And now I'm taking the LR, and now I'm draining off all the red blood cells, all the white blood cells, and the broken fat cells. I repeat that step. It's really quick. This is one of my previous fellows. She's doing it. And then what I'm doing is I'm draining it and passing it into, so now you can see, Sam, see how thick this fat is? It's like a pasta extruder. And now I'm sizing the fat. That one step quickly, I sized it and put it into 1 cc syringes. So basically it's through the screens to size it. And that's when I was using the Dermapose. Now I tend to use the sizing steps with the PureGraph Boost. And these are just some examples. This is kind of lower bleph with fat grafting. Same thing here. Same thing. This is at like a couple months. This is a full facial fat grafting. And that's it. So I think, you know, the future, you play that video, the future is kind of using fat for regeneration. And whether you take like a macro fat, micro fat, or a quote unquote nano fat, you can see the consistency of the fat cells just by looking at it. You don't have to know. I mean, you just know microfat is a lot easier and nanofat is very watery versus a macrofat kind of product. That's it, guys. All right, I'm going to throw it over to my good friend, colleague, Sam Lamb, who is really a master with fat grafting. I've learned a lot from like watching him and hearing. I'm excited to hear about his philosophy. Hopefully it will make me better with doing, consulting patients. So with that, Sam Lamb.
Dr. Lamb, real quick, we have one polling question before you begin.
Oh, go ahead.
Thank you so much, Dr. Bloom. That was excellent. If everyone could just answer these questions quickly. And also, I want to remind everyone, if you have any questions, put it in the Q&A and we can see them real time. And then we will filter them to both the surgeons to answer at the end of the presentation. Okay, and we're going to be closing the poll shortly here. Go ahead, Oren, and close the poll. And thank you, Dr. Lamb.
Okay. Should I start?
Yes.
Okay. So really appreciate Diane and also Jason's participation. I've always learned something a lot from Jason. Tonight, what I'm just talking about is sort of like a fireside chat, just to talk a little bit about my 20-year history of doing fat, the foibles, the problems, and where I've evolved and how I've come over to the Pure Graft camp, why I choose to use them. I don't have any disclosures with them. I don't have a financial arrangement with them. So this is something I believe in. So, I've been doing fat for 20 years. I learned it from the Glassgolds. I basically was really using centrifugation with pretty good results for many years. And I was using sometimes a little bit of Restylane to touch it up. And there were some issues where I'm going to talk about that with periorbital fillers causing long-term issues. And in the last 5 years, I've really migrated away from using any kind of periorbital fillers to touch up fat. I think it's problematic and really needed to look at how can I get more consistent results. I think that from a harvesting perspective, I felt I was pretty good. My injection method was sophisticated and consistent, but I think the weakest link in the chain for me was the processing. I don't think it's necessarily the closed system that's the critical component. I think it's the beautiful filtration that this product has that has allowed me to get much better results and more consistent results. They're not 100% consistent, as you've heard in Jason's talk about the fact that you can't have 100% prediction. It's not going to be 100% take. And I think that is part of the issue with fat. And I'm going to talk a little about how to communicate with patients better, what I call right versus left brain results. And I'm going to talk to you a little bit about sort of what I think fat is good for, what I think it's bad for, what I think there are limitations with fat grafting. So this is more just sort of a general conceptual talk, and I'm not going to go through all the mechanics, which Jason has done already so eloquently. So I'm just talking about sort of what has worked for me, what it hasn't worked for me. I really look at fat periorbitally being, no, it is the most challenging, but I'm going to do a little video at the end and talk about how it can be actually quite straightforward and simple. But really, it's where the money is. It's the area where people look the best. It's the area that, even though initially can be frightening for someone starting, it is the area that provides the most bang for the buck. I think that, like, for example, nasolabial grooves, jaw lines, other areas, are less predictable. I rather work in the lower face with anti-gravitational surgeries such as a facelift, neck lift component to improve that area. I really sort of structurally think about the face into halves. So the upper half of the face is more of a volume issue, and the lower half of the face is mainly gravitational. Although I do put fat into the marionette lines, into the nasolabial groove. I put it, into the lateral cheek area. I put it into zones that I still believe merit volume. At the same time, I think that the eyes really have it. And I think that's really where the results are important. I really think that the vast majority of what I see in the periorbital region is a volumetric collapse. Of course, there are issues with having fat herniation in the lower eyelids. And of course, there's dermatochalasis and brow ptosis as well. The vast majority of what I'm doing in the periorbital region is a very conservative skin removal of the upper eyelids only as necessary. And then a transconjunctival lower blepharoplasty combined with fat grafting. I have tried nano and microfat, and unfortunately, I think I used the other competitors' treatments and really wasn't getting good results with it. I just got the sample to try the new nano fat with the Bimini's product, so I can't really speak of it. I literally did it this last week. But at least when I was using micro and nano fat with a different company's product, I really couldn't get sustainable outcomes. And micro fat, I could not get good longevity in terms of structural integrity. And with nano fat, I really saw very little regenerative results, as probably what Jason has testified as well with this. So I really use macro fat for everything. I use it around the eyes. I use it in the entire face, and I don't use any micro fat. So I don't do any extra processing step. It is something that, as you know, around the eyes, technically it's more challenging. So it's an area that requires a little bit more skill to apply, especially if you're using macro fat with greater longevity. At the same time, I find that the results are more consistent and achievable with very minimal results in terms of contour deformities or other problems. Where I find that the technical details, I'll give you a quick summary, and it'll be more shown in a video format, which is that for the lower eyelids, the key, if this is not clear to you, is that it should not be placed parallel to the rim. It should be placed perpendicularly, and you're going to have a little bit of a release of the arcus marginalis along there. And you want to really place it deep, and you really don't want to place it near the ciliary margin or anywhere above the orbital rim, in my opinion. When I'm placing it into the upper eyelid, I'm just following a plane of least resistance in the subcutaneous plane. I don't know where that is, but I just try to follow that rim and place that in there. And I place that after I've done the upper blepharoplasty component. Those are probably the key technical pearls. It's better to just watch the video that I'll play in a few minutes. I have I've seen with hyaluronic acid-based fillers really long-term problems in my hands, and so I've really abandoned it. And I've seen it in other people's hands coming to me. And the problem with hyaluronic acid volumization around the eyes is really that there's a migration issue. And as you may or may not know, even 7, 8, 10, 15 years later, a filler that was placed still migrates. The biggest problem for me is making that conversion of people that have had periorbital fillers over to fat grafting. The problems I've encountered is it's really hard to completely eliminate the hyaluronic acid. I use a cannula. I use a dilute product, about 0.2 of hyaluronidase to 0.8 of saline. I slowly dissolve it. I use an ultrasound nucleus to guide me in placement of the dissolve. I start about 6 weeks before I do fat grafting. And the problem with the conversion is several-fold. Fillers have a level of precision because they don't absorb per se like fat. It's not a graft. And so that's a great thing. The precision is higher with fillers, but fillers have that migration, Tyndall effect, etc. So when patients are used to the superiority of a filler, it's hard to convert them to fat because fat has some level of variability, which I'm going to talk about with some slides coming up. So this is why I'm very cautious with patients. If they have a little bit of a weird bump under their eyes from fillers, I just do a little dissolve, and I actually try not to convert them to fat. If they've got major problems, they want to convert to fat, I'll go through a sequential dissolve and convert them to fat. And I always explain to them this right versus left brain result, which I'm going to go into now. So I'll show you some case studies, and I use those photos to describe to patients what the limitations of fat are. And so what I tell them is that I'm very confident with fat grafting around their eyes that you should look more youthful, more attractive, more rested and better. And that's what I call a right brain result. But from a left brain result, I'm not going to efface every tear trough. I'm not going to knock out the orbital rim hollow. I'm not going to make you symmetric. I'm not going to make things perfect. And I grade those into like what I call A, B, and C results, sort of like a grade report. And I'll show you some examples of that. So I call these right brain, I almost always achieve an A, but I may get an A, B, or C. And that way, what happens is patients go initially through an overfilled result for the first 1 or 2 weeks. Then they get this near flawless result for 1 to 2 months. And then they go through, okay, I'm a little disappointed, especially people that don't live in Dallas, but they have to fly back and I have to show them a result or whatever it may be. So what I always try to tell patients is you're going to have a little dip. And if you have a C result or a B result, don't go back and touch it up because you're only going to get a marginal increment. The goal is just to look better. So that communication, I think, is really, really important for patients to have, to understand. And I'll show you some photos with that. The next component is something that I no longer do. I don't put fat into the anterior cheek. I define anterior cheek basically as the volume that sits below the mid-pupil of the eye. I find that, I have had to correct my patients from 10 years ago because at least in Texas, people gain a few pounds over time. And this is a very good retention. It's even great retention with centrifuge fat. And the buccal zone is a continuation of this. If you listen to my lectures from 10, 15 years ago, I talked about how great that is. I don't like my results, and I've had to go back and liposuction these results. So another component of correcting fat is if you have an overabundance of fat in certain zones, you can liposuction it with very little risk of contour deformity. What I basically use is a 1.2 millimeter tulip cannula, no financial affiliation with any companies I'm mentioning. And I just basically use the same cannula that I inject my fat with. I use a 1.2 for my fat injections, and I just suction it like I'm harvesting fat. So harvesting fat is another subject, but you don't want to over harvest in one zone. So there's a component where people talk about, suctioning face is very risky for contour deformities. I really don't see that to be the case. If you're using a small enough cannula, like a 1.2 millimeter cannula, you can easily suction it. If you've got an area under the eye and there is a lump there, it's hard to suction that. I've had to take out lumps. It's not very common. It's actually quite rare, but I make a small incision in the orbital rim. I go in there and I cauterize and shrink it down and then close it. And I use a little botulinum toxin, very dilute in the area, helps the scar heal incredibly well. So I talked a little bit about volume versus gravity. I really think that, you heard a lot of dermatologists say if you put enough volume in, whether it's fillers or fat, that you're going to have some kind of anti-gravitational impact. I think that's bogus. I think volume is volume, gravity is gravity, and skin is skin. And that's how I articulate this to patients. The final thing is fluctuating weight, I think, is a major problem. I've mentioned this to you already. And I think that patients, especially when you're dealing with young individuals, I do a lot of hair restoration. And I think that doing hair transplants in 20-year-old men is risky oftentimes because you don't know what their future hair loss is going to be. You do know it's actually going to get worse over time, and you don't want to run out of donor capacity for that. But it's similar in the sense that when I'm dealing with a very young individual, when I'm doing fat, I don't know what their weight history is. I'm worried about, I ask them about their mother, father. I'm very conservative with the amount of fat I put in, or I just tell them, let's wait on that and not do it. So that's one thing, is that fat is a live graft. It's not a static filler. So this is what I call a result, which is pretty flawless around the eyes. This is what I call an A minus. And these are, again, really just to have you understand how I communicate with patients. It's not to say they're actually a grade, but I'm just telling patients that, look, you may get different outcomes, but if you look on every single patient, they just look better, no matter if they have a little bit of hollow left. And that's what happens is they go through that phase where they look too good and they go down, they go, well, I need a touch up. But I always say the difference between an education and an excuse, an education is told before, excuses afterwards. So if I tell all these patients at the very first consultation, at the pre-op session, every time I see them afterwards, they won't be as disappointed. And I always show them the photos. So even this guy here, who's actually quite hollow afterwards, and I did a transconjugal F, I've done fat grafting around the eyes. To me, he still looks better. And this is probably one of my worst results. I love showing this. Now, she is lifting her brows. If I didn't do a brow lift on her, I'm sorry for that inconsistency. But I do show that it's asymmetric, it's hollow, it's not perfect. But at the same time, I still think it's better. I'll show this little video. If it gets a little boring, we can cut it off. Let me hit play here. I think it's going to play. Warren. So this lady had an upper lower blepharoplasty, as well as she's doing a full face fat transfer. She's not doing a facelift. Just in terms of sequencing of this procedure, it's always the same. I always harvest the fat, let it be processed. Then I do the upper blepharoplasty. I close with a 709 and I just take out skin, because part of my philosophy, as you know, is volume restoration. That's a huge part of the rejuvenation. I think of it like a balloon that's deflating. So when I reinflate it, it looks good. And so I think, in my personal opinion, we take way too much off the upper lid. If you go back and look at yourself when you're in your 20s, you'll see that this crease was not super high. You did not have this high arch brow. So I really believe fat grafting is my principal method of doing this. However, if you've got an eye bag or you've got saggy, crepey skin, you've got to take some of that out. So the sequence always is harvest first. As she's processing, I do the upper blepharoplasty. I have a second assistant that helps me with the lower bleph. The lower blepharoplasty I always do transconjunctivally. My opinion with this is that a skin muscle flap has a small chance of a canthal distortion. I've seen this almost every week in my practice, so I try to avoid that. So it's always it's harvesting, upper blepharoplasty, lower blepharoplasty, fat injections, which I'm about to show you now, and then if I'm going to do a facelift, I do that at the end. I like wrapping my patients at the very end to minimize hematoma for one night, including drains, and then I take off the dressing. They don't wear a dressing. But that's the sequence I do every single time. If you follow the same sequence every time, you have less risk of problems. At the end of the procedure, I will do a little bit of a CO2 fractionated laser. I'm not going to film that. I'm just showing the fat grafting, but that's going to be at the very end. I just do that to tighten up the skin. I do not believe in skin pinches. I do not believe in removal. She does have a corneal shield in that's lubricated into the eye. This is the area that people talk about having problems with the fat. So I really want to explore the lower lid in depth so you understand this. The best way to understand the lower lid is it's a semicircle here, right? So we need to approach this perpendicular to the rim. The mistake that creates lumps is a parallel injection. So I don't do fillers anymore because I've seen long-term hyaluronic acid migration, but when I did fillers on the lower lid, I always approached it parallel. The trick with the lower lid is you must approach it perpendicularly. When I have taught this in the past in cadaver labs, you will feel this arcus marginalis release. That's basically a fibrous adhesion of the lower lid retractors down to the periosteum. So I'm creating a little bit of a release. You will feel you puncture through it. And so I'm going perpendicular. The reason I have 3 entry points is I find that if you try to do it all from one area, you're going to have problems in having the parallel. For example, if I try to approach the lateral canthal region from the medial aspect, I am essentially doing it parallel. But if I'm doing 3 arbitrary points, it doesn't matter where they are, these entry points that I've entered with an 18-gauge needle, standard non-no-core, I'm able to approach the rim perpendicularly. When I approach the rim perpendicularly, I'm able to minimize that risk of having an overfilled a lumpy orbital rim. You want to put very small aliquots. So you're talking about a 50th to no more than a 20th of a cc per pass. And so I'm going to be having my orbital rim protect the globe further, and I'm going to feel that. So a large part of this is feeling. You're going to feel when I go in there, you're going to feel a release,
And then I'm just going to go back and forth across this, dancing across the bony rim, back and forth, back and forth, back and forth. The same issue that I talked about with the harvesting applies to the injection method, which is if I start torquing it, if you're inexperienced, you're going to go in here and torque it, and you think you're in the same place. But if you go in here, watch this. If I go in there like this, okay, and she doesn't have much torquing underneath, but if you see this, the skin tenting, it means you're just going through the same place. You're going to create a lump there. So you want to go and tear through this arcus every time, and you're going to go in and out and tear through the. So you do not want to twist. You want to go in and out, in and out, in and out, in and out, in and out. When I'm doing this, I'm very focused on counting. It's like when I do a hair transplant, when I'm making sites, I don't talk. So I'm trying to do a lot of the explanation on the front end so that I can concentrate on the placement and not say too much during the surgery. But I'm usually, people want to know volume. So in general, with this type of graft, I'm putting probably on average 1.5 to 2 per half rim. So I go in and put, and then on the lateral, depending on the bag, I put 1 to 2 there. And then here on the outer canthus, I put in about 0.5 to 1. And I would always encourage you to start with lower volumes. You can always add more, because if you create problems, it's hard to correct these. If you do have an overfilled rim, you can go in there, put a bipolar in there, try to knock it down. In the worst case, you can make an incision on the orbital rim, and it heals really well. Multi-layer closure, of course, you don't want to do that. In 20 years, I've had to only do that one time. So that's just something that just is another pearl with this. And when I started doing fat grafting years ago, I realized that the lateral canthus must be treated separately. If you try to fill it from this point, you're too parallel, or if you leave it alone, you're going to create a lateral dip that doesn't look good. So those are the pearls with this. Now for the upper lid, it's actually just a plane of least resistance. There is not as critical a placement in this area. I just feel it passed through a plane of least resistance. It's probably submuscular, just because the skin and the muscles are quite adherent. It's preseptal. And when I'm injecting it, I'm not as worried about the micro allotment of injections. The area that's critical to place very little is here. Same thing I talked about with the fat. If you feel it getting stuck, take it out of the body, clear it, and then continue. Obviously don't clear it into someone's eyes, but just clear it a little bit, wipe it off, and go back in. This is a 1.2 millimeter tulip cannula. I use this for everything. I don't use disposables. I use ones, you can use whatever you want. I find the 1.2 millimeter to be the workhorse for everything. They do make a 0.9. I find it to be too fragile in my hands, and I use a 1.2 for everything. So we're going to start this process. I go into the 18 gauge. Hand is protecting before I enter, and then I'm just going to go in here and just place it. The key I just want to be filmed is my finger here, and maybe actually a little bit of this here, if that's in the view too. So you can see I'm just going back and forth, placing the 1 cc. And Joy, show this part here. Here, don't show the face if you don't mind. She's asked not to show that, but here you can basically see how fast it's moving. Okay, it's just little bits. The fat is progressing. Just show how. Oh, Joy, over here, right here, right here. No, here, Joy, here. Look at this.
Okay.
Okay, show this here. So you can see, this is the speed of the placement because you can't see from inside, and that's basically how I'm applying it. Okay. Can you see? Can she see? Yeah. Mm-hmm. Good. And that's it. Okay.
Okay. So I think that's the end of my presentation. I am open to any Q&A with Jason now.
We're gonna do one more polling. Oh, go ahead, Dr. Bloom, and then we'll do.
I have a couple questions for Sam, but that was awesome. So first of all, Sam, so tell me about like when because I just did this today, right? So you've booked a patient for lower eyelid bleph and fat grafting, and they've had like a ton of filler in their eyes. And so like I saw a patient today when they come in for their pre-op, I usually start the dissolving, which is about a month prior. But why only use like why so dilute with the Hylenex?
I just don't want to over dissolve everything around it. So I may go up to 0.3 or 0.4, but I'm just scared to I've had that before where the whole thing goes, all the tissues go down.
Yeah. I mean, I tell them they're going to look a lot worse before they get better, but that's why they're having surgery. Like I want to get as much filler out of there as possible. So, I mean, personally, I think I put like 0.9 cc's of Hylenex directly into her today. to dissolve everything. And then I'm like, you're going to look like super hollow, but that's why we're doing the surgery. And so they like, so I mean, that was my technique. I was just,
You know, it's
interested.
a good point. I think it's a valid point. I've just been burned with having them too hollow, but you're right. You're going to put fat there anyways, you know, so it's not a bad point.
Yeah. And the other question is when you're talking to patients about, I was just, sorry, I was taking some notes while you were talking, so it was great. When you're talking to patients, and it's like, I love that idea of, telling that, but do you offer them, I get it. I tell them that you're going to look better, but what would you say? Do you offer them kind of like a percentage that the take on the fat is in general? Or even if you don't offer that to patients, what would you say that you're using your current techniques? What percentage do you get of take with your fat grafting?
So what I remember a lady many years ago, about 12 years ago, that I was doing acne scar corrections, and she said, Dr. Lamb, I thought you promised me 50% improvement. I thought she had like 75% improvement. So I realized one thing about percentages is that I tell the story to the patients when they ask me about percents. I tell them the exact story. So I said, my percentages, your percentages are misaligned because I don't know what you could deem as percentages. All I say is that when we think about percentages, we also then fall back into the left brain. So we need to get out of the left brain, go to the right brain, because I'm very confident you should look a lot better afterwards, but you won't look perfect.
But if you, I mean, not talking to
Oh,
patients,
so I don't know,
the result.
honestly. It's tough call for me. I would still say, you know, as you saw some of my results, I still get some underperforming results. But the difference with pure graft compared to centrifugation is one is I get much more consistency. And number two is I don't get a lot of C results anymore. I do get Bs. I get Bs to As is really what I get. I do occasionally get some Cs, but those Cs still look so much better that if I tell the patient beforehand that, hey, you're going to get, you may get a left brain C, but you're still going to look great, then I think we're good. But I don't know the percentages. I just know that my results are much more consistent than I got with the centrifugation method, and I'm much happier with them.
And then just one last corollary to that question is, if you're doing the fat grafting, and do you overfill the patients by a certain percentage when you're looking at them?
Yeah, it's a good question. And I will tell you, it's hard to understand overfill, like especially in the periorbital regions, because you really can't see it when the patient is supine and you're putting it in there. It's always a guesstimate, right? So I don't even know if I'm overfilling, underfilling, but even I listened to that video. I shot that video maybe about, I think, a year ago for the Cummings textbook, and my numbers have actually gone up a little bit, you know, so I'm now on the medial orbital rim, probably averaging 2 to 2.5 cc's, and the next one also 2 to 2.5. Lateral one is maybe 1 cc. So I'm averaging probably 4 to 6 cc's per lower rim. And is that overfilled? Not. I mean, you can't. It's not like a filler where I'm sitting there watching the volume come up. You're almost just, they're supine. It's a guesstimate. So I don't even know if I'm overfilling. I guess I'm now progressive filling more, you know, as my comfort level increases with the product.
All good.
We have a couple questions in the chat. We're going to do a poll real quick. If we can answer this real quick, and then we'll get to the questions in the chat. In the Q&A, and Dr. Bloom and Lamb, you can see those too, but I'll read them. We'll start from the bottom and go up. Okay, so while we're finishing, Dr. Fisher, Dr. Ted Fisher asked, Do you have a role for PRP and or exosomes in promoting angiogenesis post-fat graft placement?
You want to answer first?
So that hasn't been, I mean, I haven't, I'm into the idea of using exosomes. It hasn't been my like practice to put them in while I'm doing the actual procedures. One thing to kind of piggyback on what Sam was saying is I don't like to touch fat up with fillers. I don't like to do that. However, I had a patient kind of recently who probably had like maybe just like she was she's a marathon runner. She probably had like a B result. And what I did use on her was Easy Gel, which is a PRF albumin, which is totally natural. And she's now going on like 6 months afterwards, and she's had a fantastic result. So I turned that one from like a B to an A. I haven't done exosomes, but it was about 8 months post BLEF and fat grafting. She needed a little bit more. She had a really high metabolism. And we did touch it up with Easy Gel, which is an albumin PRF, and she's doing really good with that.
My answer is pretty short. The answer is no. But I think, exosomes right now, I've really been underwhelmed with them in hair restoration. I tried them. PRP as a standalone for just skin things, I just have not been happy with. I do use it during a hair transplant procedure. We got to be careful, as you probably know, with exosomes, as they're still in that very gray zone of FDA clearance. I think you need to be in some kind of clinical trial or something to be able to use it. So I'd just be cautious that from a legal perspective. But I think that I think that these things are, I did use, actually, to tell you the truth, I remember 10, 12 years ago, I was using PRP, but I was using it at the time when I was centrifuging fat, and I did not see a measurable improvement. So I can say that I did it for about a year, and I just realized it was a waste of money. So I stopped doing it.
Thank you. Another question is, have you had any issues with incomplete removal of HA fillers followed by fat grafting? And how do you handle patients with negative vector and volume loss and festoon?
So I could answer first this time. The answer is yes. I've had to go back and dissolve more. Maybe what I'll do with Jason's advice is a good point. Why not just blow them out and make them really hollow? I've been always cautious because I've seen that. But I've had it, and I had it where I think I over dissolve them a little bit, and they go through that period of time where they're over dissolved because I really want to get rid of it. And it's probably a better idea to get rid of it on the front end rather than afterwards. And so this is great. I always learn something. It's a great point. And afterwards, and then it just comes back. I just got to go back and dissolve them more. And I had that issue when I was using less dilute product, and I didn't have an ultrasound guidance for it. How do you handle patients with negative vector and volume loss and festoons? So negative vector to me is never a concern for me. And the reason is I don't do a skin muscle flap. So I don't worry about the analogy of tightening the belt on a sort of fat belly and having it slip down on the globe. So removing fat from transconj is safe in a not negative vector, in my opinion. Adding fat is safe in a negative vector. I don't think the negative vector even enters in my brain while I'm working on them. Festoons is a separate category. That is a nightmare. If it's a very small degree of festooning, I will put in like a little cautery subcutaneous, like a needle cautery to manage it. But if it's decent enough, I just cut it out. And I know that sounds scary, but I always say let the punishment fit the crime. And if festoons are a problem, you just got to cut the damn thing out. And what I do is I cut it out. I close it with in multi-layers with a 5 monocryl deep. And then I close it with a 6-0 Vicryl on the surface of the skin, interrupted and running. I let it sit there for 6 weeks or so. and I will inject a very dilute botulinum toxin, about probably 20 milliliters per 100 units. So very dilute, place it in there. Actually, no, I'm sorry, I use 40 units. So very, very dilute amount, place into the incision. And sometimes I'll see them once a month, put a little bit of more botulinum toxin. I may do a little dermabrasion, and it typically heals really, really well.
So I'll answer this first. So first of all, incomplete removal of HA fillers followed by fat grafting. So first of all, like Sam said, I do blow them out. I like to really, so like this woman that I injected today, she's a month prior to her lower lid blephin fat grafting. I injected almost a cc of hyaluronidase between the two eyes. We have something in my office that I've kind of created, and that's called the press test. And so patients can do this at home, and they're surprised every time when I bring this up to them. And the press test is, if you press normal skin, right, it bounces back, it comes out. But they'll say, well, I'm like, well, have you ever had fillers to your lower eyelid area? And they're saying, no, no, no. And then I do the press test is, if you take a Q-tip or your finger and you press the area of the infraorbital area and it pits, like pitting edema, and it just stays there indented, there has to be filler there. There has to be filler underneath there because nothing else does that. So I tell them and so like this woman, I told her in like a week or two, if she can still pit her lower eyelids, she needs to come back for more dissolving. So I will totally blow it out. And that is a quick and easy thing. Like all the injectors in my office know, like, oh, she has a positive press test. That's just old filler there. And these people, they've had filler 6-7 years ago, and products that we were injecting back then, like they are really hydrophilic, and being able to dissolve them is really important beforehand. I have had one patient where, I thought it was completely dissolved. I did the surgery, did the fat grafting. She just had a little bit of residual malar edema, like at the 4-month time period. And again, it still pitted, and I put a little bit of Hylenex in it, got rid of it. So that I've had one case where she did have a little bit of residual, and she was a case that I removed prior. Last thing is, how do I handle negative vector? So negative vector it's a mid-face deficiency. So you need to, unlike Sam, will inject into the anterior mid-face along the rim to kind of like support that area. Additionally, festoons are really, I would say maybe the one case where I do a transcutaneous skin muscle flap. I do basically an orbicularis hitch, like an orbital, where I take the orbicularis muscle and sew it to the orbital tubercle. That was what 2 of my fellowship directors during my fellowship in 2010 did for every case. And so that is the one case, because festoons are truly, and then I'll fat graft them for the volume loss, but festoons are overlapping orbicularis muscle. That is not malar edema. I think just that is one of the biggest kind of misconceptions, is people lump malar edema, which is a disruption of the lymphatics that live right in that area, whether it's from surgery, whether it's from filler, whatever it is, it's a backlog of swelling in this area, versus a true festoon, which is an overlapping of the orbicularis muscle. And in those cases, you kind of have to sling the orbicularis up. That's how I handle it.
Thank you, Dr. Bloom. Dr. Land, there was just a question on fat versus wash fat versus unwashed, viability and duration. In your experience, is wash fat always better?
It's so easy for me to say, just because in my experience, one is better than the other, that it's universal. And that's not always the case. I think it really depends on, when I trained to do fat in 2001 in Japan, my mentor there was using wash fat in an open system, and he got great results. You know, centrifugation I did great with it for many years. I just find that this system provides a little bit better better percentage hold. Again, I can't quantify that percent, as I mentioned earlier. I think everything lives and survives. There's a certain percent that will survive. This is the question of is what. So I think that thinking of fat being sometimes temporary, sometimes not, is erroneous. There is a survival percentage. You must think of it as a long-term volumizer. But I just would say that I do like this product a lot in terms of improving survival.
Perfect. Dr. Bloom?
I mean, when I was doing my fellowship, they did a gravity method with a strainer that like you could get at a kitchen store, and that they sterilized. And then I came out and I was using centrifuging, and then I was using Telfa. And it's like the nurses hated me for a while because they're like, preparing it on the Telfa, and it's like a mess everywhere. And now my nurses love me because this is easy. And I've found that it just works great for me. I mean, you can see by washing it, just the pure color alone, that you're getting rid of the red blood cells that definitely lead to more bruising. Having more red blood cells in there. And I see people like fat grafting on Instagram, and they're like throwing this like red stuff like up under the eye. Like it has to bruise more. It has to, because you're basically putting red blood cells, RBCs, into the area. So that alone, I think, helps with the downtime. And that is one of the biggest reasons why I'm using it. And anecdotally, I certainly have not done a study, but I will agree that my patients have less downtime because there's less inflammation from the unnecessary cells and broken fat cells when you wash it.
Excellent. Well, for the sake of time, we have run over, and everyone, thank you so much for joining us. We have one last polling question, but you feel free to email us any questions, and we will make sure Dr. Bloom and Dr. Lamb get those and can answer them for you. I just would like to thank Dr. Lamb and Dr. Bloom. Excellent presentation, so informative. And as Dr. Bloom said, you two learn a lot from each other, but you teach us so much. So all the participants as well, thank you so much for joining us. And we'll let you know when we have our next webinar. Good night, everyone.
Good night.
Bye, guys.